In this video, we'll discuss Alzheimer's disease, its causes, pathology, clinical features, different stages, and treatment. So what's Alzheimer's disease? Alzheimer's disease is a slowly progressive degenerative brain disorder of unknown etiology and results in progressive memory loss, impaired thinking, inability to learn, reason, and make judgment. There is disorientation and personality and mood changes. Alzheimer's disease is the most common cause of dementia, and 50 to 70% of patients suffering from dementia are suffering from Alzheimer's disease. Vascular dementia being the second most common cause of dementia. 20 to 40% of people with the age more than 85 and 15 to 20% of people between 65 to 75 years of age suffer Alzheimer's disease. It's more common in females and more in low educational group. How about the diabetes? Diabetes increases the risk of Alzheimer's disease by threefold. Alzheimer's disease patient may have a past history of head trauma with concussion. Pathology of Alzheimer's disease. There is atrophy of the brain with dilated ventricles and shrinkage of hippocampus and diffuse atrophy of cerebral cortex. Cortex shrivels up and damages the area involving thinking, planning, and remembering. Shrinkage is especially severe in hippocampus, and hippocampus is critical to the formation of new memories. Most serious pathology at autopsy is seen in hippocampus, temporal cortex, and nucleus basalis of Maynard. In severe stages, there is visual problems. So what are the microscopic features in Alzheimer's disease? Extracellular and intracellular. In extracellular, there are neuritic plaques containing A-beta amyloid, and in intracellular, silver staining neurofibrillary tangles are found in the neuronal cytoplasm. Neurofibrillary cytoplasmic plaques represent abnormally phosphorylated tau proteins, and they are associated with microtubule. Tau proteins are paired helical structures associated to microtubule and interfere with its blood supply, thereby damaging the neuron. What's the normal function of tau protein? Normally, tau protein function is to assemble and stabilize microtubule, but increased accumulation of tau protein disturbs the normal process. And number 3, A-beta 42 amyloid in arterial walls of the cerebral blood vessel. A-beta 42 is the most toxic of these proteins. What's the first biochemical injury in Alzheimer's disease? Accumulation of soluble amyloid fibrils called oligomers lead to dysfunction of the cell. Accumulation of oligomers eventually leads to formation of neuritic plaques that contain amyloid, proteoglycans, and other proteins. Amyloid precursor protein APP are normally neurotropic and neuroprotective. And what's amyloid angiopathy? There is accumulation A-beta 42 amyloid in arterial wall of cerebral blood vessel. Accumulation of beta amyloid in cerebral arteries is termed amyloid angiopathy. Amyloid plaques obstruct cerebral or neuronal blood flow. Amyloid angiopathy can lead to ischemic infarction or hemorrhage. Neurotransmitter deficiency in Alzheimer's disease. Which neurotransmitters are deficient in Alzheimer's disease? Neurotransmission that decrease especially is acetylcholine. Acetylcholine transferase converts acetylcholine to acetylcholine. Cholinergic pathways originating in the nucleus basalis of Maynard play a role in memory function. Decrease in acetylcholine causes degeneration of neuron in the nucleus basalis of Maynard. And what's the role of mercury in Alzheimer's disease? Mercury inhibits the function of acetylcholine esterase, thereby reducing acetylcholine. There is also a decrease in norepinephrine in locus coeruleus. And what are the genetic and chromosomal abnormalities in Alzheimer's disease? DNA fragmentation is found in degenerative neuronal disorders including Alzheimer's disease. APP, amyloid precursor protein gene on chromosome 21 causes typical neuropathology and is a hallmark of Alzheimer's disease. A-beta amyloid that accumulates in Alzheimer's disease is a smaller unit of APP. There are three types of secretases that break APP into alpha, beta and gamma parts. The alpha secretases cannot break APP into A beta, but beta and gamma secretases break APP into A beta. APP gene accumulates on chromosome 21 and initiates Alzheimer's disease in Down syndrome. So it's the accumulation of APP gene on chromosome 21 in Down syndrome. So most Down syndrome patients have Alzheimer's disease by the age of 40. Next, apolipoprotein gene E on chromosome 19 has high binding for A beta, which is neurotoxic and causes Alzheimer's disease. Next, mutation in chromosome 14 produces hyperphosphorylated tau protein, which causes formation of neurofibrillary tangles. Now, familial Alzheimer's disease. Familial Alzheimer's disease is due to two different types of presenilins. Presenilin 1 is on chromosome 14. Mutation in this gene causes early onset Alzheimer's disease. Course is short and more progressive. And number 2, presenilin 2 is on chromosome 1 and mutation in this gene probably causes late onset Alzheimer's disease. Mutation in PS1 presenilin is the most common cause of early onset familial Alzheimer's disease, usually before the age of 60 but may occur before 50. ApoE gene on chromosome 19 causes late onset familial and sporadic forms of Alzheimer's disease. 25 to 30% of non-demented Caucasian people have at least one ApoE4 allele, and 40 to 65% of Alzheimer's disease patients have at least one E4 allele. However, some patients with Alzheimer's disease do not have E4 allele, whereas some with E4 allele never suffer Alzheimer's disease.
In early stage of Alzheimer's, you have problems with daily keeping track of finances. Patients may be lost on walks and while driving an automobile. In the middle stage, patient is unable to work easily, lost and confused, requires daily supervision. Language may be impaired especially, and then comprehension and naming of objects may be impaired. Also impairment in fluency and comprehension, and there's repetition. They're also unable to do simple calculations or tell time. They may have a form of cortical blindness due to changes in visual cortex, hallucinations, delusions. They may accuse their spouse of infidelity. They may not recognize old friends. Think a visitor is burglar. Nighttime wandering may be disruptive to the family. Shuffling gait would be present with generalized rigidity, with slow awkward movements. This looks Parkinsonian but rarely has rapid rhythmic resting tremors. End stage Alzheimer's, patient will be rigid, mute, incontinent, and bedridden. Hyperactive tendon reflexes. Generalized seizures may also occur. Myoclonic jerk of muscles or whole body raise the possibility of CJD. Death from malnutrition, secondary infection, or heart disease.
Diagnosis of Alzheimer's. EEG may be normal. CSF shows increased tau protein. CSF has A beta amyloid is decreased, whereas tau proteins are increased. How about CT and MRI? CT and MRI may be normal in the early stages, but later they show diffuse cortical atrophy. MRI shows atrophy of the hippocampus also. The MRI or CT scan showing only diffuse or posteriorly predominant cortical and hippocampal atrophy is highly suggestive of Alzheimer's disease. PET scan has demonstrated that earliest changes in Alzheimer's disease are in parietal lobe. Next, functional imaging studies in Alzheimer's disease show hypoperfusion or hypometabolism in the posterior temporal parietal cortex. Differential diagnosis of Alzheimer's disease: normal pressure hydrocephalus, Parkinson's disease, B12 deficiency, and pseudodementia and tumor. Treatment of Alzheimer's disease: number 1, cholinesterase inhibitors. They include tacrine, donepezil, rivastigmine, and galantamine. And number 2, NMDA antagonist, memantine. And antidepressant, SSRI and mirtazapine, and antipsychotics for Alzheimer's disease patient having psychological problems. Patients usually die of intercurrent infection.